Hello, my name is Jade Lewis, and my research question reads, what is the effect of specialized sound/music therapy on stroke patients to improve function of the upper extremity? The availability of literature on the research question chosen was very limited. The lack of research made it difficult to identify sufficient evidence on this topic. The first study, completed by Zondervan et al. In 2016, was a randomized controlled trial with crossover design type and level 2 evidence. This particular study looked at the efficacy of the use of a music glove versus that of conventional tabletop home exercises. There were 17 participants aged 35 to 74 with moderate hand impairment following stroke. The participants were randomized to 3 weeks of home-based exercise with either the music glove or conventional tabletop exercises. Grips from the music glove included key pinch, pincer, and finger-thumb opposition with second, third, and fourth fingers. The primary outcome measure was the change in the Box and Blocks test score from baseline to 1 month post-treatment. However, the motor activity log, quality of movement, 9-hole peg test, and research arm test were all utilized within this study. Although both groups significantly improved their Box and Blocks test score, there was no significant difference found between each group. The music glove group did exhibit significantly greater improvements than the conventional exercise group in motor activity log, quality of movement, and amount of use scores 1 month post-therapy. Limitations found within this study included the use of a small sample size, technical errors that could arise from the laptop/music software, and the accuracy of the data collection. The second study, completed by Rong et al. In 2015, included 14 patients ages 18 to 80 with impaired hand function following stroke. This study was a randomized controlled trial with pre-test, post-test design, and level 2 evidence, investigating an intervention involving music-supported therapy with the use of a keyboard. The 2 groups in the study were given a keyboard and received step-by-step training for 30 minutes, 20 times, over 4 weeks, in addition to conventional treatments. The difference between each group was that the keyboards in the control group could not produce sound. Patients were assessed using the Wolf Motor Function Test before and after training. Both groups showed improvement in motor function assessed by the Wolf Motor Function Test scores, and the improvement in music group's hand function was significantly better than that of the control group. Due to the limitations in clinical work, it was difficult to achieve randomization. It was also hard to obtain true conclusions due to the small sample size, and limited cases were selected due to such rigid conditions for recruitment. The third study, by Scholes et al. In 2016, was a randomized controlled trial with pre-test, post-test design, and level 3 evidence. This study included 25 subjects aged 32 to 86 where they investigated the use of a sonification box training to improve arm movements and function in stroke patients. There were 2 groups in the study, and both received an average of 10 days of musical sonification therapy. The only difference between the 2 groups was that in the control group, there was no sound being played back during the training. The 15 patients in the music group showed significantly reduced joint pain in the Fugl-Meyer assessment after training. Limitations found in this study include floor and ceiling effects and a small clinical trial with limited statistical power. The last study, by Raghavan et al. In 2016, used a quasi-experimental mixed method pre-test, post-test design with level 4 evidence. 13 subjects completed the 45-minute intervention twice a week for 6 weeks. The intervention used repetitive isolated movements of the affected upper limb while playing many different musical instruments. There was no comparison intervention completed in this study. The primary outcome measure used was the Fugl-Meyer scale. However, there were secondary outcome measures which included 2-point discrimination test, modified Rankin scale, well-being index, and the stroke impact scale. There was significant improvement found in the upper limb, motor movement impairment, sensory impairment, activity limitation, and well-being immediately post-intervention that persisted at 1 year. Limitations found within the study include quasi-experimental mixed method design, the small sample size, and that there was no control group. The implications for occupational therapy practice found within these studies are to enhance the functional abilities of stroke patients through rehabilitation. This can be completed through the use of music therapy interventions that focus on upper extremity movements to further improve the activities of daily living and instrumental activities of daily living. Future research studies should involve larger sample sizes, which include music therapy interventions, with the use of occupational therapists alone to further justify this treatment approach.